Dr. Satish Kamanathan, Professor Chitma, Dr. Asha H.S., Professor CMC Vellore, and Dr. Uma Kamal Saikia, Professor, Bhakati Medical College. Here's a quick reminder of the rules that we are going to follow. Each presentation will be allotted 7 minutes. There shall be a warning bell at the 6th minute. The screen will be turned off at the 7th minute. Participants, please try to complete within your allotted time. Good luck. The first presenter we have is Dr. Pankaj Singhania, IPGMER, Kolkata.
Very good morning, respected judges, teachers, organizers, and delegates. Today, this morning, I am presenting the first oral presentation, and the topic of discussion, which we've done in our department at IPGMER Kolkata, will be treating children with osteogenesis imperfecta with bisphosphonates because they hardly have anything to offer them. So, as we know, osteogenesis imperfecta, hereby referred as OI, is a heritable disorder of the extracellular matrix of collagen of bone, associated with bone fragility, dentinogenesis imperfecta, blue sclera, hearing defects, joint and spine abnormalities, primarily from COL1A1 and COL1A2 mutations, associated with frequent fractures, delayed union, malunion, and a very poor quality of life. Since treatment options are very limited, there is actually no curative treatment, and most options involve rehabilitation. IV cyclical bisphosphonates have been tried to reduce fragility fracture in these patients. Results with pamidronate and zoledronate are equally good, and this leads in improvement of quality of life and increased aerial BMD in these children who are really suffering. So in our center, we had around 19 patients with osteogenesis imperfecta in this duration who had a fragility fracture history with or without a family history. Whole genome sequencing was done for diagnosis of OI. After exclusion of other hypocalcemia and renal involvement, IV zoledronic acid was given to them as per the schedule I discussed, and they were followed up for fracture incidence after infusion. This was our cohort, a total of 19 patients. The average age of our cohort was 5.6 years. They were all very short, all of them less than third centile. The age at first fracture was less than 1 year. Their total number of fractures was more than 7. Upper limb fractures were lesser than lower limb fractures. They had their first infusion of zoledronate at an average age of 2 years, and till now, till I make this presentation, most of them have received at least 2 infusions of zoledronic acid with us. These are other details of our patients. Most of them were male. Few had family history, in fact very few. The presence of consanguinity was also there in few of our patients. Blue sclera was fairly common in our cohort. There was one patient with a hypoplastic callus, that is osteogenesis imperfecta type 5. Dental involvement was rare in our cohort. Hearing involvement was also rare, and there were no cardiovascular abnormalities detected by echocardiography. We know that osteogenesis imperfecta is classified as per the Sillens classification. So most of our patients were either the Sillens 1 or Sillens 4. There was also involvement of Sillens 3 and an unclassified variant of Sillens 1/4. There were very few patients of the Sillens 5 or Sillens 7 classification. These are the genome sequencing details of all our patients. We could find mutation in 14 of our patients. And as we can see, most of the mutations are either COL1A1, which is the commonest mutation, or COL1A2. There were few of IFID-M5 or CRTAP mutation, and there was one patient with osteoglophonic dwarfism. And these are the variants and the type of inheritance that we have in these subjects. So we had 14 patients with detected mutations among the 19 patients that we are treating currently. These are some of the representative X-rays. As you can see, twisted bones, fractured bones, and at the bottom panel on the right and left, we can see there is hyperplastic callus formation, which is very characteristic of osteogenesis imperfecta type 5. We only have one patient of OI type 5. This is the zoledronic acid infusion protocol that we follow as per NHS, which varies according to the age of the patient, and the dosage accordingly varies as per a cycle of either 3 month, 4 monthly or 6 monthly cycles are given for these patients. And this is a dramatic improvement after giving zoledronic acid infusion, whereas the fracture rates per year in this cohort is somewhere around 2 or more. It reduces to less than 1 per year after giving zoledronic acid infusion for these subjects. Adverse effects, as we know, there can be some adverse effects with zoledronic acid infusion. There are few. 6 of our patients had experienced minor adverse effects in the form of chills and pruritus, but they were self-limiting only with paracetamol, and none of the patients experienced severe adverse effects with zoledronic acid infusion. So it was kind of very well tolerated. So type 1 and type 4 osteogenesis imperfecta are the most common type in our cohort. Blue sclera was fairly common. Here it was normal excepting in 1. COL1A1 mutation, as we've seen, is the most common type of mutation. Fracture rates improved dramatically after giving zoledronic acid infusion in these patients. They had really good quality of life after we treated them. Treatment was generally well tolerated. There were very few side effects. Biochemical parameters, as we do before and after infusion, generally remained unaltered, and there were no significant changes in biochemical parameters in these subjects. We have some limitations. As we know, it's a very rare disease, so we have a small sample size. There are only 19 patients. BMD data, there are limitations with collecting BMD data in small children. We are collecting BMD data, and we will also see subsequently as to what is the improvement in bone mineral density in these subjects. Quality of life, we are seeing quality of life is improving, but an objective assessment of quality of life is also being collected and may be available in near future. And the follow-up duration, as you know, is mostly of 1 to 2 years. We have just 2 or little more than 2 years follow-up. A longer follow-up is required to see how they do and whether at all there are any adverse effects. To conclude, osteogenesis imperfecta is a debilitating disorder, and we have little to offer these children. Most rely on our orthopedic colleagues for fracture management, deformity correction, and rehabilitation. Cyclical IV bisphosphonates are the only form of medical therapy that can be offered to these patients. IV zoledronic acid is safe treatment for fracture prevention. Fracture rates decrease even after 2 doses of IV zoledronic acid. Therapy is generally well tolerated in these subjects, and we have been treating them. We have found no significant adverse effects. We have found improvement in fracture rates. We have found improvement in quality of life. These are our children, some of our children with osteogenesis imperfecta. They are really suffering. We are trying to do something for them. And as it is said, what I'm trying to cultivate is not blind optimism, but radical hope. And all of these children, and I sincerely say thank you to the organizers and everyone over there. Thank you so much.
Thank you, Dr. Presentation. You start your time. Just do you all assess the growth pattern, growth velocity?
Madam, as I've already said, they were all very short, less than the third percentile at presentation. It's been a duration of maybe 1 year for most of them, maximum 1.5 to 2 years since we've been treating. The height, they have been growing, but exact parameters in terms of change in standard deviations, we have not been able to collect the data. Maybe that we will do after a little more than 2 years or more. But we are expecting that their growth and stature will also improve with treatment because of absence of fractures, because most of their short stature is because of recurrent fractures and spinal involvement. So,
good presentation.
thank you, sir.
How long do you intend to continue this?
So this is a question, the answer to which is also not known to us. It is believed that they can be treated for a very long time, provided they do not have any adverse effects. Even if we stop treatment, since we know that zoledronic acid or bisphosphonates accumulate in bone, they may continue to get the advantage if we stop treatment after they have stopped having fractures. So maybe if they do not have fractures for a continuous 1 to 2 year duration, we can stop treatment and see, since zoledronic acid advantage will continue with them. But the duration of treatment, since this treatment is largely experimental, and though it is being given all over the world, and long-term data are not available, we are not sure as to when we are going to stop treatment for these subjects.
It's good that you have genetic data for any 14 of them.
Yes.
Do you have any trend towards any particular genotype, genetic mutation which is having a better
Since COL1A1 and COL1A2 mutations are more common, and and COL1A1 is the commonest type of mutation in type 1 OI, which otherwise also has a good prognosis. Even we have an adult patient with COL1A1 mutation of type 1 OI who we detected incidentally because the child was affected. So these patients who already have an initial background good prognosis tend to do better on bisphosphonate therapy compared to the other ones.
Thank you.
Thank you, sir.
Have you generally screened the parents of these children?
Madam, we have done Sanger sequencing for that subject in which, in those subjects in which blue sclera was also seen in the parents. In fact, the mothers accompanying these children may have blue sclera. But without a fracture history of blue sclera, we did not do the Sanger sequencing or tracing for all these subjects for the parents.
Have you done BMD measurements for these?
These, madam, initially we thought that BMD assessment will not be required because OI itself is a fracture-prone disease. And since some of these children are less than 5 years, getting the software for children less than 5 years BMD was difficult. They're very small, so the aerial BMD may be smaller for them as well. But recently, we have started doing BMD for all our subjects, and the BMD is surprisingly -6, -7, or even -8. Very poor BMDs for most of the subjects.
Are you using any objective QoL scores?
Yes, no madam, we have not yet used the objective QoL scores, but we plan to use a QoL score to see how they do in otherwise in quality of life. Thank you so much. Thank you.
A small announcement: to prevent conflict of interest, judges from the Institute of the Presenter will not mark the particular presenter. Our next speaker is Dr. Uday N.K. from Guwahati Medical College.
Good morning everyone, good morning judges, teachers and my friends. Today I am presenting a case on hypophysitis. Diabetes insipidus as a sole presentation of hypophysitis. Hypophysitis, as you all know, is an inflammation of the pituitary gland and it could be primary or secondary to a local or systemic process. And there are three types of hypophysitis: adenohypophysitis, infundibular neurohypophysitis, and panhypophysitis. And it will be classified as primary or secondary to some local or systemic process. The prevalence of the hypophysitis is around 0.2 to 0.8%, and these are the clinicopathological forms, among which lymphocytic hypophysitis is the most common, followed by granulomatous type hypophysitis. And they present usually with anterior pituitary dysfunction or posterior pituitary dysfunction, or they can also present with mass effects like headache, visual disturbance, and even as hyperprolactinemia. And posterior pituitary dysfunction in the form of diabetes insipidus, which will be usually seen in 27% of patients. And here we are presenting the case series of 6 patients which are admitted in the endocrinology department in Guwahati. And our inclusion criteria was the patients who presented DI, who were diagnosed by older professional test, and the stop dimension we took was greater than 2.6. And here you can see the stop dimension. This is the site of pituitary insertion, where we took, actually we can take anterior-posterior or transverse diameter. We here took anterior-posterior diameter. And another inclusion criteria was bulky pituitary with or without. Coming to the patient diagnosis and details of the patients, there are totally 6 patients. Among these are the first 3 patients, and as you can see, the first 3 patients are all female with a median age of, in the age range of 43 to 55 years, and the symptom duration was 2 months to 6 months, who all presented with polyuria and polydipsia. And as you can see, the first patient had anterior pituitary dysfunction in the form of hypocortisolism and hyperprolactinemia with inappropriate low FSH, and the corresponding to the MRI finding was also having infundibular bulky pituitary. But however, this patient did not have infundibular thickening. The rest of the patients have infundibular thickening, and as you can see, all the patients had absence of pituitary bright spot. And the second patient had infundibular thickening 3.2 mm and hypocortisolism, as well as anterior pituitary dysfunction. The third patient, however, did not have an anterior pituitary dysfunction. However, the patient had thickening. These are the next 3 patients, and they are all male, age range from 4 years to 62 years, and they present with symptom duration of 2 months to 1.5 years. Mainly the presentation was polyuria and polydipsia, and one patient, there is 6 patient, which was also a case of Langerhans and histiocytosis, also on urinary found a short stature, and the 6th patient also had growth hormone deficiency with a low IGF-1, and you can see that there was a stalk thickening. And etiologically, the patients, the first 3 patients which I described earlier, they were originally diagnosed as lymphocytic hypophysitis because after ruling out all the other causes of secondary causes of lymphocytic hypophysitis, and they were initiated on treatment with desmopressin. Everyone was initiated with desmopressin, and the ones who were treated with lymphocytic hypophysitis were started on steroid therapy with the initial dose of 40 mg for a period of 6 weeks. And also we can see on subsequent MRIs, which was around 3 months later, we had resolution of the thickening of the pituitary in the MRI, and also the hypocortical which was earlier seen was resolved. And this is the next set of patients I told. And the 4th patient was also having auto test positivity, which was suggestive of tubercular origin, and is still under follow-up, and we are planning for CSF analysis to rule out chronic infections in the form of TB. And the 6th patient is a hematological patient, as I told you, he is in follow-up with hematology, and is also on chemotherapy with lenalidomide. These are the first patients. As you can see, these highlighted ones are the abnormal values, and here the difference we can see. This is the bulky pituitary and the resolution of the pituitary size here, and this is the second patient with the anti-TB positivity, and the thickening of the stalk was resolved in the subsequent MRI, which was taken after 5 minutes. This is the 3rd patient. Here also we can see there is the resolution of the thickening. The thickening which was seen earlier is resolved in the subsequent MRI, which was done 3 months later. This is the 4th patient in whom we found a positive motor test, and he also had 4.1 mm thickening, and we are planning for CSF analysis. And this is also the 5th patient. There was a elderly male. He was having top thickening along with hypogonadism and hypocortisolism. This is the 6th patient. That is the patient who had Langerhans and histiocytosis, 4 years, 8 months old child. So summarizing, we can say that the age range was around 4 to 62 years, and DA was a common presentation among all the hypophysitis patients, and the mass symptoms are not seen in our patients, and the antipituitary dysfunction was seen in around 4 patients, and there is a good response to glucocorticoid therapy in 3 patients, and 3 patients are still under follow-up, and everyone who required desmopressin, and even though the antipituitary dysfunction was resolved, the requirement for desmopressin was not, we could not taper the patients. But however, with desmopressin, there was a good response in the patients. And quoted from an article, hypophysitis the growing spectrum, which states that the most frequent finding in MRI is thickening of stalk with or without gland enlargement. And actually, the diagnosis requires definite diagnosis requires biopsy. However, it is very difficult, it is very challenging, and even it can be associated with comorbidities. So it has to be the risk can definitely show the weight. And the mainstay of treatment is glucocorticoids. So we can infer that from the study that lymphocytic hypophysitis, as we have seen, it usually presents in the peripartum period, and most of the like 50% presents in peripartum period. That is not the case here. All types of peripartum, and this whole presentation was diabetes insipidus, and the response to glucocorticoids is good. However, the diabetes insipidus persisted and required lifelong therapy. Thank you.
Good collection of cases.
Thank you.
I just want to know if you had analyzed the radiological aspect according to Gutenberg classification for hypophysitis. There is a classification for hypophysitis.
Yes.
Gutenberg's. Have you analyzed that with all your 6 cases? Whether they fit in with the probability of
Gutenberg, I'm not sure, sir, but firstly I know the primary and secondary hypophysitis.
So in your series of 6 cases, how many are primary and how many are secondary hypophysitis?
4 patients are primary hypophysitis and secondary hypophysitis are 2.
So in all these patients, we had upfront started with high dose steroids.
No, sir, only the patients who among whom we have ruled out other causes of diabetes hypophysitis, and on whom we made a presumptive diagnosis of lymphocytic hypophysitis. In them we started steroid course.
And no one had a significant mass effect for these patients among all these.
Yes, sir. Though pituitary bulky pituitary was found in a couple of patients, and biochemically they had some hyperprolactinemia in the form of stalk effect. Even then, the clinical presentation of headache and visual disturbance or any other symptoms suggestive of effect was not present, and mainly they presented with body-weight cholesterol or hospital. And so on evaluation, on further evaluation, we were found to have central DI in order to prevent intestinal retreat, and on further evaluation we found to have some findings in the MRI in the form of stalk thickening or bulky pituitary. So we further evaluated and we found to have another this thing was not this. Other secondary etiologies we could not come up with. Only those we made a presentation of lymphocytic hypophysitis because it is the most common.
Thank you.
What other radiological evaluation were done for all the patients before deciding as well?
We wanted to note infiltrative, infective, as well as even neoplastic etiologies. So for infiltrative, for example, for sarcoidosis, we evaluated with the calcium levels and ACE levels, serum ACE levels, and for autoimmunity, we evaluated with ANA levels, and even to rule out neoplastic etiologies like German which present stalk thickening, we did AFP levels and beta HCG levels, and to rule out infectious causes like tuberculosis, we did a Monro test among the patients.
Did any of your patients have a pituitary biopsy? Did they get a pituitary biopsy?
No, none of the patients had a pituitary biopsy.
Did you treat any of the patients with IV prednisone?
No, ma'am. We went ahead with oral prednisone, ma'am. For higher prednisone.
Are you aware of any evidence in relation to that? The use of methyl prednisolone?
Yes.
What is its effect on?
Like they say, when there is a hypophysitis effect, like particularly mainly lymphocytic hypophysitis, they say some studies have shown that actually depending on the symptom severity, sometimes they will have, if it is mild to moderate, we can give an observation file. If it is moderate to severe, and we can go ahead with the glucocorticoid therapy, and only surgery is indicated only in those patients in whom there is severe mass effect and known as optic asthma, and if there is a need for different diagnosis when we are not completely sure of what is the diagnosis.
What proportion of your patients recovered any pituitary hormone analysis?
50%. Biochemically, there was a recovery of the antipituitary dysfunction, and that is hypocortisolism among our patients without resolution of protein. Thank you.
Thank you. Our next speaker is Dr. M.D. Ramesh Raja from Medical College, Calcutta.
Good morning, respected judges and delegates. I am going to present some cases of primary untreated long-standing primary hypothyroidism presenting with some pituitary abnormalities. The kaleidoscope of pituitary abnormalities in primary hypothyroidism. My first case, a 19-year-old female presented with primary amenorrhea, intellectual disability, along with features of overt hypothyroidism, and he had also had a history of 3 months of headache. And his birth history was not significant, and his headache was not associated with vomiting or visual disturbance. On examination, he has overt features of hypothyroidism like broad nasal disease, drooping of eyelids, short stubby hands, and there is double-line addition of malocclusion of jaw. And she also had disproportionate severe short circuit with a height scale of -10.33, and her sexual maturity was pubertal, and her thyroid gland was not palpable. On investigation, he has severe hypothyroidism, very low 84, and TSH was more than 100, and thyroid ultrasound shows thyroid gland is absent, and technician scan suggestive of thyroid aplasia. So the diagnosis of primary hypothyroidism is made, and in view of long-standing hypothyroidism and headache, we also perform the MRI, which shows there is homogeneous contrast enhancement of homogeneous contrast enhancing cellular mass reaching up to optic chiasma. Her other hormone function shows LH was pubertal, and particular hormone and prolactin was slightly high, likely due to lateral hyperplasia. And we started on initially low dose of levothyroxine, followed by titrating to current dose of 100 microgram. And after 6 months, her TSH was normalized, and he had been after 5 and 5 months. He also loses weight of 3 kg and gained height, and there is significant clinical improvement in her intellectual level. And these are the changes in her clinical appearance, and these are also the breast development after 6 months. Repeat MRI was performed after 1 year of levothyroxine replacement, and there is significant reduction in pituitary size after 1 year of levothyroxine therapy. Second case, an 18-year-old female presented with features of overt hypothyroidism along with primary amenorrhea. On examination, there are also features of suggestive of hypothyroidism, and her third function reveals FT4 of 0.08 and TSH was more than 100, and ultrasound next shows absent thyroid gland. And her MRI also shows the enhancing cellular mass that averting the optic chiasma, and her other pituitary function, particular normal clot slightly high, LH was pubertal. As patient has no features of visual field defect, initially treated with low dose of levothyroxine is gradually titrated to higher doses, and they will follow up. After 6 months, her TSH was normalized, symptoms of hypothyroidism improved, and there is clinical improvement in sexual maturity also attained the menarche. But after 1 year, MRI was performed, but there is no significant reduction in size of the pituitary, and the pituitary hyperplasia persists. We also tried the 6 months of supraphysiological doses of levothyroxine, more than 2 microgram per kg, but still the pituitary enlargement persisted. Even after FT4 and T3 was higher than the upper limit of normal, the case is still not suppressed. And another case, a 32-year male presented with features of hypothyroidism and intellectual disability. He had features suggestive of hypothyroidism. He also had macroorchidism. His thyroid gland was not palpable. His thyroid function also shows overt hypothyroidism. Her IgG was negative, and ultrasound next shows the thyroid gland appears atrophic. And MRI reveals the cell has enlarged, but it is partially empty. His cortisol was 5.6, which fails to stimulate after short-acting test. Testosterone normal. And during treatment, he initially started with low dose and then gradually titrated to upper doses, and also treated with oral hydrocortisone replacement. And we can follow up, there is significant clinical improvement. These are some case reports published in the literature, which in long-standing antecedent primary hypothyroidism, there is pituitary hyperplasia. Around most of the cases, it reverses, like in some cases it may not reverse. And there are also case reports of apoplexy of the hyperplastic tissues leading to panhypopituitarism and empty cellular in case of long-standing primary hypothyroidism. Along with there are some case reports of coexistent TSH secreting adenoma along with thyroid aplasia presenting with primary hypothyroidism with TSH secreting adenomas. So pituitary hyperplasia is defined an absolute increase in number of one or more adenohypophyseal cell types, manifesting radiologically as pituitary enlargement beyond what is normal. It can be physiological as in pregnancy, lactation, or pathological. Pathological most commonly occurs in endocrine insufficiency, like in primary hypothyroidism or primary hypogonadism. And loss of negative feedback of circulating treatment info leading to increased TRS secretion leads to Transdifferentiation of somatotrophs may also occur that can lead to pituitary hyperplasia, and it is more common in long-standing untreated congenital hypothyroidism. Response to levothyroxine can be variable, so primary hypothyroidism should be considered in the differential diagnosis of pituitary gland lesion, and examination of thyroid function test in patients with cellular suprasellular mass revealed by MRI may have unnecessary surgery.
Thank you, Miss. Just a comment when you give photos. When you give photos of patients. Why do you think, what is the cause of persistence of pituitary hyperplasia in the second case you presented?
Second, maybe in long-standing cases due to continuous stimulus, there may develop some degree of autonomy. That can lead to persistent, as well as if we have started the supraphysiological dose, even after achieving a F4 and T3 of more than normal, there is TSH still not get suppressed. That may suggest there can also be some TSHoma, underlying TSHoma as well.
So how do you know about it? If you feel that there is an underlying TSHoma?
If there is a visual field compromise, we have to do the transmural spinal surgery for that.
And how do you diagnose it? Clinically, what would be the presentation?
Clinically, initially they present with hypothyroid, but if have coexisting primary hypothyroid, they can present like primary hypothyroid as well.
Any biochemical test and hormonal test you can do, which will be suggestive of TSHoma?
Alpha subunit TSH, alpha subunit we can do, or TRH stimulation. There is no response to TRH stimulation as well.
What was the cause of hyperthyroidism? For these cases, I didn't catch it. They all have thyroid regenesis?
Yes, all of the thyroid agenesis or dysgenesis, congenital hypothyroidism.
The second case did not respond to treatment, and so would you consider sending the patient for surgery?
If there is visual field defect, we will follow up the patient. If there is visual field compromise, we will plan for surgery. Or in long run, it may regress as well. We will follow up the patient.
What about puberty in patients with primary hypothyroidism? What happens to puberty in patients with untreated primary hypothyroidism?
Both delayed puberty as well as precocious puberty both can occur in primary hypothyroidism, long untreated one.
First case, what is the bone age?
Bone age is 5 years.
First case. So it looked like it was a classical congenital hypothyroidism.
First test was congenital hypothyroidism. Bone age was 6 years.
Thank you. Gentle reminder to everyone, we have a morning snacks organized for you from 8:30 a.m. onwards. Our next speaker is Dr. Moria Hovo from IQ City Medical College, Bangalore.
Good morning, respected judges, my teachers, and delegates. Today I will here to present a case titled on a cross-sectional study to assess risk factors for cognitive decline in type 2 diabetes patients. I am Dr. Moria, the presenting author of this study, and my co-authors are Dr. Anurag Bharali, Dr. Swadhi Biswas, and Dr. Suham Das. So we know diabetes is an increasing complication nowadays, and cognitive dysfunction is increasingly recognized as an important comorbidity of diabetes mellitus. So there are so many complications. Among them, co-occurrence of diabetes and poor cognitive status share some common risk factors. So assessment of the risk factors like glycemic control and duration of the diabetes might affect the cognitive status in such patient hold the utmost importance. Here the objectives of my study to assess the prevalence and association of the cognitive dysfunction in people with type 2 diabetes according to the severity of the diabetes in HbA1c, duration of the diabetes and other risk factors. I took my study in Sugam Clinic, Vidhannagar, Durgapur. It was the cross-sectional observational study. The duration of the study was 5 months, started in April 2023 and ended in August 2023. My sample size was 156 with taking the confidence level of 95% and margin of error 5%. With the study approval taken by the ethics committee of the Sugam Clinic and after taking all the inclusion and exclusion criteria with their permission, all the study participants were assessed according to the Montreal Cognitive Assessment or MoCA questionnaire. Here, all the MoCA score less than 26 are considered as cognitive dysfunction, and all the more than 26 were considered as normal cognitive function. All they are divided into two groups on the basis of presence or absence of the cognitive dysfunction. The demographic and other level data like duration of diabetes, diabetes severity, and other comorbidities were collected from their treatment records, and all the treatment data were statistically analyzed with descriptive statistics, unpaired test, manually U test, odd ratio in MS section, and other standard statistical tools. Type 2 diabetes patients aged more than 35 years who gave consent were included in my study, and the patient with history of learning disability, primary neurological illness, prior history of cognitive dysfunction, not related to diabetes, brain injury, stroke, epilepsy, Parkinson's and pregnancy were excluded from my study. Now come to the result. Here we analyzed the data of 156 participants were divided into two major groups. They are type 2 diabetes with cognitive dysfunction or poor cognition, including 62 cases, which is 32% of my cases, and the type 2 diabetes with no cognitive dysfunction or good cognition, including 94 cases, which is 68% of my cases. Here, 8 of the patients were significantly higher in poor cognition groups, which is 55 years, as compared to the good cognition group, which is 48 years. Female had more cognition dysfunction compared to male, but there is no significant association found. Among the comorbidities, only obesity was found to be significantly associated in poor cognition. Regarding the demographic parameters, higher age groups, which is more than 45 years, and lower literacy below the graduation level had a significant association. Cognitive dysfunction was significantly associated and increased duration with increased duration of diabetes, taking the cutoff of more than 5 years, and HbA1c taking the cutoff more than 7.5%. So these are the socio-demographic parameters showing the majority of our participants from age group of 45 to 60 years and the education level below undergraduates. These are the charts showing the gender distribution of the both groups, where you can see the majority of the participants are female in cognitive dysfunction group, and the chart showing the residence type of the both group, majority of the participants are from rural population. But there is no significant association. So this is the distribution chart of HbA1c percentage and duration of diabetes. Here you can see majority of our patients had HbA1c less than 7.5% and also the majority of the patients have the duration of the diabetes less than 5 years. This is the distribution chart of comorbidities in both the age group. Here you can see obesity is the most associated factor in cognitive dysfunction. These are the comparison of the age, duration and severity, where you can see the good cognition, poor cognition patient had a mean age of 55 years as compared to good cognition patients who has a mean age of 48 years. And the duration of the diabetes was poor in more than 7 years as compared to good in less than 3 years. And severity, you can see the poor cognition, the median HbA1c is 8.1 as compared to 6.5 in good. These are the subgroup analysis for the association of the cognitive dysfunction. These are the showing more than 45 years, and education level below EG shows the poor cognition. These are the also sub-analysis for association of cognitive dysfunction. Diabetes duration more than 5 years and diabetes more than A1C level more than 7.5%, showing poor cognition and significant association. Come to the discussion, risk of cognitive dysfunction was higher in older age group more than 45 years. According to the Robertol, we also found HbA1c level more than 7.5% and 10% associated to 2.8 times and 3.6 times as risk of cognitive dysfunction. And the duration of diabetes more than 5 years called a statistically significant association with poor cognition, similar to Hajari, Ma et al. As compared to 7.5 years. Here the limitation of the study are the other causes of the cognitive dysfunction were included and the sample size was small with limited duration of the study. To conclude, the statistical significant positive association of cognitive dysfunction was found in increased diabetes severity, which is A1C more than 7.5, duration of diabetes after 5 years, age more than 45 years, educational background level below UG level. And prevalence of the dysfunction is more in female than rural population, but it was not statistically significant. There is no conflict of interest and the funding was nil. These are my references and that's all. Thank you.
Thank you. Nice study.
Thank you, sir.
Actually, this is just a cross-sectional study.
Yes, sir.
This is a cross-sectional study.
Yes, sir.
So, in this cross-sectional study, I presume age is the most important factor which is responsible for the cognitive decline. Yes. So, how to deal age is the most important factor in the conclusions. If age is the most important risk factor here, does it come out in your conclusion?
Age is significant association where you can get all the p values raising 0.5. So with increasing age,
So you have shown all three factors as age,
duration,
duration,
and severity.
So if age was driving all the other factors, whether these were independent of all the three were independent of each other.
Sorry, sir, I didn't get your question.
All the three risk factors, duration of diabetes is independent of age.
No, sir. There may be some connection. Actually, we did not get our study also.
Were there any patients on insulin?
Yes.
What proportion of the patients were on insulin?
What
What proportion of patients were on insulin?
Actually, we don't have to know about it. Actually, it's a cross-sectional study. Now we only took the HbA1c values and the duration.
Does hypoglycemia have an effect on cognition?
Yes.
Because in your study it was predominantly the hyperglycemia which
actually-
had a major impact.
Yes.
But was hypoglycemia captured in the study?
Yes.
That's the question.
Right.
Was OSA evaluated for obstructive sleep apnea?
What's the observation? No.
What do you think could be the mechanism of cognitive? As ma'am has said, hypoglycemia is one.
Yes.
What are the other mechanisms possible to cause cognitive dysfunction like this?
Other mechanisms cognitive dysfunction.
Yes.
There may be some other causes of dementia, like in senile, in Alzheimer's,
But you have excluded all that.
Yes.
In your opinion. You also showed that obese persons have more cognitive
Yes,
dysfunction.
yes.
So can you correlate something obesity and
We
cognitive
took
dysfunction?
BMI more than 30 or the as per these questions.
Have you heard of insulin resistance in the CNS?
Yes.
Could that be a factor?
It can be a difference.
Another thing regarding females, how many were post-menopausal?
Many of the focus. The maximum was
Is there any relation between estrogen and
cognition.
cognition?
Cognition to maximum was cognition. but we did not study the association or anything.
You can try to sub-analyze.
Yes, sir.
Okay.
Yes, sir. Thank you, ma'am.
Thank you. Our next presenter is Dr. Roger Dave from NRS Medical College, Kolkata.
Good morning, respected judges, delegates, and faculty members. The topic of my study today is prevalence of clinically significant liver fibrosis due to non-alcoholic fatty liver disease in Indian individuals with type 2 diabetes mellitus. The study was conducted in Department of Endocrinology and NRS Medical College under the guidance of Professor Nilanjan Sengupta sir and Dr. Swami Goswami sir. So as we all are aware that up to 80% of the type 2 diabetes patients has some degree of steatotic liver disease. And fibrosis per se in NFLD correlates with the hepatic and extrahepatic manifestations of NFLD. And the prevalence of this hepatic fibrosis in Indian type 2 diabetes mellitus patients are not well documented. So keeping all this in mind, the aim of our study was to estimate the prevalence of transient elastography proven to clinically significant liver fibrosis among patients of type 2 diabetes mellitus attending diabetes clinic at a tertiary center. So the tool that we used was vibration controlled transient elastography, better known as FibroScan, and it is nowadays a non-invasive standard of care method for detection of hepatic fibrosis, having advantage to take it at a point of care. The first parameter that we saw was the LSM, that is liver stiffness measurement, and when it is more than or equal to 8 kilopascal, it indicates the significant liver fibrosis. The second parameter that we saw was controlled attenuation parameter, that is CAP. When it is more than 237, it indicates steatosis, and the degree of steatosis was defined on this basis. The report of FibroScan in a single sitting we used to get both the reports of CAP as well as LSM, and at least 10 readings were taken. More than 60% success with interquartile range less than 30% was taken as validation. So the study design was cross-sectional descriptive evaluation study conducted between July 2022 to February 2023, and the inclusion criteria was patients with type 2 diabetes mellitus having age between 18 to 65 years attending the diabetes clinic. The participants who were excluded were the men and women consuming a significant amount of alcohol every day, having hepatitis B or C positive, any known history of concomitant chronic liver disease or having thyroid dysfunction. Those patients who are having AST more than 5 times the upper limit of normal, and patients already receiving some sort of pharmacotherapy for NFLD like pioglitazone or salmeterol, and those patients who are having some secondary causes of hepatic steatosis like intake of drugs like corticosteroids or estrogen receptor modulators. The study design was out of this 655 patients were screened, out of which 52 were excluded because of these reasons, and then 603 were finally participated into the study, and then FibroScan was done where both LSM and CAP value was taken, and on the basis of which the patient were divided whether having steatosis or not, or whether having fibrosis or not. The result, the baseline characteristic of all the participants, as we can see that median age was 48 years and 59% participants were female, having a mean BMI of 24.9 and the duration of diabetes was 7 years. At the age-wise distribution, maximum number of patients belong to this two decades, that is 41 to 50 years and 51 to 60 years. Talking about the prevalence of significant liver fibrosis, out of 603 patients, 137 were having clinically significant liver fibrosis, which means 22.7% of prevalence, and the factors that were significantly associated were BMI, higher AST, ALT, and presence of higher level of steatosis and low level of platelet count. Among this 137 patients, 34 patients were having LSM more than 12, which means they were having advanced fibrosis. The prevalence of steatosis, out of 603, 355 patients, that is 59% patients were having various degree of steatosis, and the factors that were significantly associated with the female, higher BMI, higher AST, ALT value, and the grade of steatosis, grade 1 was present in 15%, grade 2 was present in 21%, and grade 3 steatosis was present in 23% of the participants. Another observation was advanced fibrosis. Transient fibrosis has its own limitation in morbidly obese patients along with very lean patients. And the results was somewhat representative of a high risk group who are attending the tertiary care centers cannot be represented at the community level. So the conclusions that we are having from this study is significant liver fibrosis is highly prevalent in type 2 diabetes mellitus patients. That is almost 1/4 of the patients with type 2 diabetes mellitus having liver fibrosis, and majority of such individuals having normal transaminase level and higher BMI, AST and ALT values and lower platelets associated with liver fibrosis.
Good study. I was just wondering if FIB-4 score was calculated.
Yes, we also calculated that is the second part of our study, that is in all patients. We have
How did it correlate with the FIB-4 score?
it correlated that is more the FIB-4 value, more is the fibrosis, and also we are trying to calculate a cutoff value, modified cutoff value for Indian patients for FIB-4 values, as the already the FIB-4 cutoffs that has been provided, that is 1.3 less than 1.3 more than 2.7 is somewhat derived from the Western population, not in the Indian population.
Fine. What is the logic behind excluding 5 times the upper limit of liver enzymes?
Sir, it was found that in those patients who are having some sort of hepatic condition because of either heart failure or having ALT, that is AST flares, or postprandial patient, the transient elastography, that is fibrosis, overestimates the fibrosis. That's why those patients were excluded. Because even though the patient is not having fibrosis because of any other reason, if AST ALT is more than 5 times, then the transient elastography will falsely tell that the patient is having fibrosis with higher LSM value.
The diagnostic criteria for NASH or for whatever new name generation.
The new nomenclature just a few months ago we saw that it has been changed to metabolically dysfunction instead of MASLD has been made. And
So what is the upper cutoff of liver enzymes in this case?
sir, in this study we have taken 40, but this new recommendation are saying that in females we should consider 19 to 25 and in male 29 to 33. That has been given by AGA guide.
I am just asking in reference to your exclusion criteria. You have taken 5 times as a
Yes, sir. In that we have taken 150, more than 150 AST was there, because in our laboratories it is 33 is given, is the upper limit of normal for AST and ALT. So that is why 15 to 33 they usually taken the reference value. So we have taken the whosoever having more than 150, we have excluded those.
What proportion of your patients were obese?
Sorry,
Obese.
obese patient. The mean BMI was 24, but it was the exact number of patients who were having BMI. I'm currently not aware of that. But
Because that is a significant
Yes, ma'am.
risk factor for NAFLD as well as for progression to liver fibrosis. So whether the proportion was higher among those who are obese. And also, what are the problems with using FibroScan in very obese?
yes, ma'am.
What was the highest BMI in your?
When the highest BMI was 30. Anyway, we have excluded because of failure of FibroScan to detect in those who are having more than 35. But those who are having more than 30 BMI, we have used our Excel probe for them. Because Excel probe is there, which is validated for detecting fibrosis. So we have used in them. Those who are morbidly obese having more than 35 BMI, anyway they were excluded because of failure of FibroScan to detect. Thank you.
Thank you. Our final speaker, presenter for this session is Dr. Abuv Deokulia from DSP Main Hospital, Durgapur.
Good morning all. The topic of my study was the study of liver clinical spectrum and neuropathy in diabetic patients. Diabetic renal neuropathies are, as you know, are one of the neurological complications among diabetic patients, and the paralysis of the third, fourth, sixth cranial nerves as a complication of diabetes. It was first recognized as a clinical entity by Ogley in 1866. Symptoms of diabetic renal neuropathy, they usually occur suddenly and it can be very sudden. They require proper clinical evaluation for diagnosis, treatment strategy and prognosis prediction. The objective of my study was to find out the pattern of diabetic cranial nerve ophthalmopathy in Eastern Indian population. Materials and methods. Total 19 patients with diabetic ophthalmopathy which were newly diagnosed or which had recurrence of diabetic ophthalmopathy were included in the study between August 2021 and November 2022. It was a cross-sectional study. All of the patients underwent thorough clinical neurological examinations. Some were advised brain imaging like CT and MRI, but generally it was basic demographics were noted and detailed examination was done by the lead neurologist at the center. The criteria for inclusion was the patient with comorbidities like smoking, hypertension, coronary artery disease, obesity, and having old stroke were included, and the patients having other causes of cranial neuropathy like stroke, infection were excluded. Of the 19 patients who were diagnosed with diabetic ophthalmopathy, of these, the 16 patients, that is 84%, were male, and 3, that is 15%, were female. The age group was generally from the middle age, and 2 patients, 10.52%, were in the age group of 40 to 50 years, 7 patients with the age group of 51 to 60 years, and again 7 patients were in the age group of 61 to 70 years. But only 3 patients were in the higher age group of 71 to 80 years. As you see the age distribution of the pie chart. The diabetic patients were divided into 3 groups based on fasting blood sugar, and less than 110 mg/dL, we had 3 patients. In the range of 110 to 180, we had 11 patients, that is 57.81%. Between the more than 180 mg/dL, we had 5 patients, 26%. On the comorbidities, only 2 patients, 10%, were smoker, and 4 patients, that is 21%, were hypertensive. In our study, the most common cranial nerve involved was 6th nerve with 9 cases, followed by 3rd nerve with 8 cases for 2%. Second and 6th cranial nerve involved for only 1 case each. All the cases were of single cranial nerve involvement, and multiple cranial nerves were not involved in any case. New onset cranial nerve involvement was found in 15% of cases only, and rest 4 cases had regular involvement of cranial nerves. As you can see there. Discussion part of diabetic cranial neuropathy is one of the neurological complications of diabetic patient, usually involving the 3rd, 4th, and 6th cranial nerve, causing acute onset of ophthalmoplegia. The 3rd and 6th cranial nerves are most commonly affected. This was what we called as Fera study. The dosage is marked and pupils are generally spread. And in diabetic neuropathy, the prognosis is relatively benign, and spontaneous recovery is expected within 3 months in most patients, and no complications are expected. Ophthalmoplegia, secondary to the cranial nerve 3rd, 4th, and 6th palsies in diabetic patient, it is considered to be a part of microvascular cranial nerve palsy involving small vessels atherosclerotic changes, as it was found by Diaphragm. Multiple cranial neuropathies can occur simultaneously in diabetic population, and sometimes it can be a presenting sign of newly diagnosed diabetes or glucose intolerance. Ophthalmoplegia in diabetic patients, they most only occur in older individuals with a long duration of diabetes, as we found similar results in our study. Now, the 3rd cranial nerve palsy can be considered, and when they are clearly documented with one of the following signs like droopy restricted upward ocular mobility, and binocular diplopia. The 4th ocular cranial nerve palsy can be considered if it is reported at the patient presents with vertical diplopia, which is accompanied by compensatory contralateral head tilt. While absence nerve palsy is considered if the ophthalmologist indicate the patient had binocular or vertical diplopia and esotropia. Hypertension, obesity, and poor glycemic control did not increase the risk of ophthalmoplegia significantly in our study, which is in line with the findings of Petelin et al. Including the most common age group found in our study was 50 to 70 years, and the male gender being the dominant. And the 6th cranial nerve was the most involved, and involvement was single, with no multiple cranial involvement, and patient had few comorbidities. Thank you.
Thank you. correlate with other microvascular complications in your patients?
No, ma'am. Only for viability was correlated. It was a prevalence study to find out the age group and the post-mortem cranial nerve involved, and comorbidities were also solved. And also that if the cranial involvement was single or multiple cranial nerve involvement was. So prevalence study was not. Otherwise factors were not considered.
Your study 6 was the most commonly involved.
Yes, sir. Yes, other studies, sir, third cranial has been found to be most common, but our study we found this cranial to be more commonly involved. But our study was limited by the less sample size, so only 19 patients were studied. And
What was the comparison? What is the number that you got? Third, how many were how many at third and normal, how many at sixth? The numbers was cranial involvement of 6 grossly outnumbering.
no, sir, nine patients involved had 6 cranial involvement, and 7 had third cranial involvement. Both these third and 6 cranial they form the majority of the cranial involved diabetic patients. Fourth, very less, and 7th also except very less involvement.
What was the average HbA1c of these patients?
Yes, ma'am.
HbA1c.
HbA1c could not be known, ma'am. Only a fasting blood sugar was taken for diabetes.
That was a lovely morning session, and a warm thank you to our judges and participants. We'll be announcing the winners at the valedictory session. We'll be having a short break for 5 minutes right now. Thank you.
topic.